Hello, my name is Ruben Mesa, and I'm the director of the Mesa Cancer Center at UT Health San Antonio, MD Anderson. And at the first Texas MPN workshop, I tackled the topic of whether or not it's correct or a good idea to use JAK inhibition in early myelofibrosis. So there's a couple pieces in there first to unpack. First, what do we mean regarding early myelofibrosis? We know that we have developed many different risk scores for myelofibrosis. And in there, whether it be the initial IPSS, the DIPSS, the MIPSS, or many of the other variants, individuals are stratified by lower, intermediate, or high risk. But those risks primarily link with issues of survival and do not necessarily give a good sense of disease burden. Does early mean lower risk? Does early mean more closely tied to the time of diagnosis? Does early mean having features that are not more advanced? JAK inhibition has been helpful in individuals across the spectrum of myelofibrosis. And we primarily started their utilization in clinical trials in more advanced cases of myelofibrosis, largely as an aspect of drug development. Indeed, before we knew these drugs were safe and effective, it was a logical place for us to begin. But over time, particularly with expanded access use trials and real-world studies, we've seen specifically that ruxolitinib has been very beneficial for low-risk symptomatic patients, low-risk individuals with splenomegaly, and similar with individuals with intermediate 1 risk. Indeed, it's really the burden of the disease, the splenomegaly symptoms, and others that suggest the likely benefit of JAK inhibition, as well as potential longer-term benefit by decreasing the inflammatory cytokines and other morbidity associated with the disease. We do not have much data yet regarding the use of fedratinib in individuals with lower or intermediate 1 risk disease, although I'm sure that this will develop as there's greater experience with the drug and real-world data. Similarly, with pacritinib, momelotinib, and other JAK inhibitors, as their experience moves from the clinical trial realm to the real-world realm regarding the extent of patients. So I'd conclude by saying that patients with myelofibrosis need to really have individualized therapy, where their prognosis is linked to their MF prognostic score is just one aspect for you to consider. I would strongly encourage you to consider the burden of disease that patient faces regarding risk of progression, regarding splenomegaly, symptoms, cytopenias. Try to develop your therapeutic plan accordingly, and for many of those individuals, that will appropriately include JAK inhibition. Thank you.